Okay, I think we can start. Professor Hackert, Professor Shrikande, dear colleagues, as the president of the Turkish chapter of IHBBA, I welcome you all to this webinar. We have two world-famous experts to share their experiences with us. I thank them again for accepting our invitation to attend. And now I yield the floor to the moderator, Professor Mert Erkan from Turkey.
Dear President, dear colleagues, thank you very much for this nice occasion. I think the topic is very important and we really have two excellent surgeons here, both of which I know, I think since 2003. Thilo Hackert, Professor of Surgery at the Heidelberg University in Germany. He is the Vice Chairman and he's an excellent surgeon and a scientist. And Shailesh Shrikande, again, the Professor of Surgery and the Head of GI and HPB Surgery at the Tata Memorial Center, is also an excellent scientist and surgeon. They have both huge experience in operating patients as well as in multidisciplinary approach in treating complex cases. Today's topic is, as you know, the borderline resectable pancreatic cancer. Should we go on right away with surgery? This would be the point of Professor Hackert. And Shailesh, on the other hand, will present the data on the issue of using neoadjuvant treatment in borderline resectable pancreatic cancer patients. This is not a debate, this is an exchange of opinions and experience. So I would like to first give the word to Professor Hackert to share his experience and the way he sees the literature. Thilo?
Okay, Matt, thank you very much for the nice introduction. And Professor Edson, thank you very much for the invitation to talk on this. Actually, I realized I had a quite similar talk in October on the invitation of Professor Dulundu on behalf of the IASCO. So I hope there will not be that much redundance if anybody attends this for the second time. But I have tried to put in some new data and some new aspects. So anyway, I hope we can manage like this. I just try to share my screen now and you can hopefully see it. I hope this works. Yep.
It works.
Okay, thank you. So borderline resectable pancreatic cancer, and I have the point of upfront surgery. Now to get started, just see if these slides can also move. Let me check. Yeah. Okay, we all know that in 2021, pancreatic cancer is not solved by surgery alone. We all know that we need, of course, adjuvant chemotherapy afterwards, and we may need neoadjuvant therapy, including chemo and chemoradiation in some of the patients. And of course, the debate at the moment is who needs neoadjuvant therapy and who does not need it. To get started, I want to show you one case that we just recently operated on, where all of this is put together, I think, in a quite nice way. This was a patient diagnosed with pancreatic cancer in July 2020. He was 48 years of age, a male patient, so really a young patient where you think you should do everything you can do. You see this tumor in the beginning invading the celiac axis here. This is the initial CT scan. And of course, everybody says, yes, this is advanced. This is not resectable at the moment. This is more than borderline even. So we put this patient on 5 cycles of FOLFIRINOX. Actually, he didn't tolerate that very well and he had to stop FOLFIRINOX. So he went to restaging in November last year, and you see this looks even more condensed in some way. The celiac axis certainly still invaded, and also the superior mesenteric artery, not really clear what happens here. So we thought, what could we do next? FOLFIRINOX is not good. So finally, we did an individual decision in Heidelberg and said we should put this patient on radiation. We did some carbon radiation with a total of 45 grays and 55 gray boost in the area of the tumor. And this was accompanied by 4 cycles of gemcitabine. Patient tolerated this extremely well, which was quite surprising. And he came back in January with a restaging. And from the images, you can see not very much has changed from the CT scan. So I said, okay, what should we do? He is 48 years of age. He has probably had all the therapies we have at the moment. And I said, okay, let's go to the OR. Let's see what we can do with this patient. We went to the OR. And as you can see here, we took out the tumor. It was a total pancreatectomy in the end. We resected the portal vein end to end. We resected the superior mesenteric end-to-end. We resected this big aberrant right hepatic artery with an end-to-end anastomosis as well. This was a little challenging, but finally it went technically quite well. And now surprising, the histology, it was a PT4 tumor after neoadjuvant treatment. He had 0 lymph nodes and he was R0 with a resection margin of more than 1 millimeter. So I think this shows you what can be achieved if you put together all the therapies we have at the moment. And this is what we should offer these patients when they are in good condition and when they are young of age. Now, coming to the actual topic, resectability, borderline, and locally advanced. Today, I want to focus, of course, a little bit of borderline, which is basically about venous involvement, a little arterial involvement, of course, as well. You know the definitions. I just want to repeat this briefly. The basic definitions are more or less anatomically. This is of the NCCN and the ISGPS, borderline resectable with a venous invasion, and the vein is reconstructible, or a limited arterial invasion. And of course, then you can say you can take this off, or you may resect the artery in some of the patients. This is the anatomy. This does not tell us what is really going on in the patient. So therefore, I think we should keep up with a better definition from my point of view, because the only technical considerations do not show the tumor and the way that the tumor will behave in the future. So now we have the IAP definition, which was published in 2017, 2018, and this is going beyond the anatomical issues. The anatomical issues, of course, are important for the surgeon, and this is quite similar to what we know, resectable, borderline resectable, and unresectable. If you have a vein that is not reconstructible, if you have an extensive arterial invasion, which is not reconstructible. But this is a little bit more detailed, because the venous invasion below the border of the duodenum is also technically not reconstructible. So this is venous invasion, but not borderline anymore, but unresectable. Now coming to the tumor biology, which is included in this definition, this is also considering what the tumor will probably do in the future. And you know, CA19-9 above 500 units or proven lymph node metastasis in CT scan or biopsy is a factor that tells us this is a poor tumor biology, and this patient will maybe not benefit from upfront resection. These are the data behind. You see when you have a high CA19-9 of more than 500, the survival decreases dramatically. And the same is true, of course, for the lymph nodes. 0 lymph nodes, you have these curves, 1 or more than 4 lymph nodes, this worsens extremely, except for T4 tumors, then everything becomes similar again. The third factor that is respected in this definition is the condition of the patient, which means you have a poor performance status. The patient will not really benefit from the operation. From my point of view, mainly because the patient will not be able to get adjuvant therapy behind, because he will not recover very well from the operation. And then if you have a poor performance status, this is also worsening the prognosis dramatically. And so these patients should probably not be included in an upfront surgery approach. So this approach from the IAP goes beyond the anatomy, which says a resectable tumor anatomically can turn into a biologically or conditionally borderline resectable or even unresectable tumor by these 2 factors. And this maybe should be considered more than the anatomy alone. Now, what about the topic of neoadjuvant therapy? I want to start with the adjuvant situation. We have very good data in the adjuvant situation for these 3 protocols, FOLFIRINOX, nab-paclitaxel and gemcitabine, About radiotherapy or sequential chemoradiation, we have no data from adjuvant studies at the moment that are really reliable and that are really high-level evidence. Now you all know the adjuvant situation, all know the adjuvant studies as PAC4. Just briefly, gemcitabine and capecitabine improves the survival to 28 months after resection. Then, of course, the PRODIG trial, FOLFIRINOX modified in this situation versus gemcitabine adjuvant was a milestone because it prolonged the median survival to 54 months and 35 with gemcitabine alone. Then you probably also all know the APAC trial. This was the combination of nab-paclitaxel and gemcitabine compared to gemcitabine alone in the adjuvant setting. This was quite disappointing because there's absolutely no difference. So these are the 3 protocols which we can transfer from the adjuvant setting to the neoadjuvant setting to consider what we should do with the patients. There are, from my point of view, good data to apply for FOLFIRINOX or gemcitabine capecitabine. We have no evidence to use paclitaxel and gemcitabine in the neoadjuvant setting, and we do not know anything about radiotherapy or sequential chemoradiation in a neoadjuvant protocol. Why is that so crucial? Because we know that pancreatic cancer is not pancreatic cancer. We do not know which patient needs what protocol of neoadjuvant therapy. We assume that approximately 40% of the patients respond to FOLFIRINOX, 40% may respond to gemcitabine-based therapy, 20% are probably complete non-responders, and about radiation sequential protocols and the duration and the response control of neoadjuvant therapy, we basically know nothing at the moment. Why is it furthermore so important? These are some data from the older SPEC3 study, and you see that the response of the patient, if you have an expression of a certain transporter, this hand1, can vary from 20% if you have the right therapy or if you have the wrong therapy for this individual patient. And at the moment, we just don't know which patient responds to which therapy when we choose an upfront protocol with gemcitabine or with a platinum base in behind. Now I want to show you some data from the Italian PACT-15 trial. This was actually resectable pancreatic cancer, but I think this is important because it underlines what I just told in the recent slide. 93 patients, a 3-arm design, upfront surgery, gemcitabine, upfront surgery, or this rather strange combination of gemcitabine, capecitabine, platinum, and epirubicin, or a combination before and behind surgery of these 4 drugs that are administered in the adjuvant setting as well. When you see the outcome, this seems to prolong survival in this randomized trial, so quite a good result. But when you look into the results data a little closer, you see that the pathological response is exactly what we expect. You have a good response in 36% of the patients, a moderate response in another 1/3 of patients, and a poor or no response in 1/3 of the patients. So this should just tell us these patients might have been just given the wrong therapy. If they had received something else, they might have responded. If they had been operated before, they might have had a better prognosis in the end. What is the role of radiation? We were asked to talk a little bit on radiation because we heard that in Turkey, radiation is applied in some of the patients in a neoadjuvant setting. From my point of view, and in Germany, this is very uncommon, and maybe I can show you some data to underline this. The basic idea for neoadjuvant therapy in pancreatic cancer is that everybody argues it's a systemic disease right from the beginning. So you should get systemic therapy before you get local therapy. So what is the rationale to add a local radiation treatment if you have the idea that it's a systemic disease? I cannot really tell that. I don't know. And because of this, we don't believe in radiation in a neoadjuvant setting at the moment. But what are the data that we have today? This was one of the first randomized controlled trials from Korea, 50 borderline resectable pancreatic cancer patients, neoadjuvant radiochemotherapy and resection, or upfront resection. You see, we talk about 27 and 23 patients in each group. When you look at the outcomes, you think, okay, neoadjuvant treatment is very good. Less positive lymph nodes, less R1 or R2 resections after the neoadjuvant treatment, and this was statistically significant, of course. When you look a little closer, you see that the survival seems to be superior, but I think the big problem of this study is 110 patients were planned in the initial planning from the statistics. The final analysis was done even before the planned interim analysis was performed, and 75% of the patients had some severe protocol violation, which from my point of view makes this trial a little questionable from the outcomes and says the evidence created by this trial is not really level 1, what we expect from such a setting. What about the Dutch PRIOPANC trial? Of course, this is the next one that is always mentioned when we talk about chemoradiation. This was surgery and gemcitabine, or gemcitabine with radiotherapy before surgery and then adjuvant gemcitabine afterwards. You see at the baseline that the ones who underwent immediate surgery were a little sicker than the ones who went to radiotherapy in the beginning. borderline and resectable cancers were quite equally distributed here. When you look at the overall survival, I think this is striking in that trial. We talk about 13.7 versus 17.1 months. And you remember the milestone and the benchmark for survival in adjuvant therapy is 28 months from SPAC4 and 54 months from PRODIG. So I think the survival times in this study are very, very poor. So I cannot see any advantage to add any radiotherapy in that setting, not even if you have the randomized controlled setting, this is not proven. And looking at the outcome furthermore, you see that in the surgery first group, there is a lot of loss in the first part of the study, which tells you that this is just a selection bias, because these were patients that had metastasis, peritoneal carcinomatosis, things like that. And of course, the only thing that neoadjuvant therapy has generated here is that you select the patients that have no of these distant metastases, and then they, of course, have a better prognosis in the end. Now coming to SPAC5, this was a trial from Liverpool and Heidelberg and a lot of other centers. 4-arm study design, surgery, gemcitabine, FOLFIRINOX, or chemoradiotherapy. This was the only time in Heidelberg when we ever did chemoradiotherapy since 2010, I think, because we had to do because of the study protocol. And you look at the primary endpoints. This was one, the feasibility recruitment rate, and second, the resection rate of R1 and R0 resections. In SPAC5, as well as in many other studies, borderline resectability was only based on anatomical issues, as we know from before, veins and arteries. And the primary outcome, the recruitment, shows you that it was quite difficult to recruit these patients, because in Germany, we still offer upfront resection to most of the patients, and most of the patients expect upfront resection when you tell them, yes, we can do an operation, and they will not accept to be included in the study, not even if you tell them, yes, we need this study, and you should please participate in this study. What about the resection rate? The resection rate between all of the arms was exactly the same, and the R0 resections also were exactly the same. Now, the secondary outcomes, overall survival, of course, neoadjuvant was superior here. And when you look at the 4 groups, FOLFIRINOX did the best. Radiation was not as good as FOLFIRINOX. This is nice. And of course, some people say this is the proof for neoadjuvant therapy. We have to have the limitation of the study. And the limitation of this study is, although I like this study, it was not powered for overall survival. It was powered for recruitment and powered for resection rate, not for overall survival. And we have included 93 patients in 4 arms. So I think nice to start to choose the right regimen for neoadjuvant therapy, but not a proof that neoadjuvant therapy is actually superior than surgery in this borderline setting. Now, some other observational studies. This is a French multi-center trial that was published in 2019. 203 patients included, most of them borderline resectable, also some locally advanced ones. Baseline data, more or less balanced here in this retrospective study, a little surprising because it was retrospectively. And regarding the outcomes, chemoradiation is better than chemotherapy alone in nearly all of the downstaging parameters. Also in the time of pre-treatment, it was longer to radiate the patients than only give them chemotherapy. The stages were anyway lower in the end. Survival from diagnosis was better after chemoradiation, and survival from surgery was also better after chemoradiation. You see, we talk about 26, 27, and 48 months. I think this is quite reasonable. But once again, these are observational data, not from a randomized setting at the moment. The prognostic factors are the same that we know. Chemoradiation was better here, and no venous resection was also a good prognostic factor in this situation. Now we go to the randomized trial, and this is the most recent trial that we have from the ASCO 2021. This was an RCT on borderline resectable cancer. Good performance status patients were included here, and it was compared if you have only systemic chemotherapy before surgery, or you add stereotactic radiotherapy and then go to surgery. Anyway, all of these patients should have received 4 cycles of FOLFOX afterwards, and the primary endpoint was the 18-month overall survival in this study. When we look at the outcomes, this is not very different in the chemotherapy and the radiation chemotherapy arms. Surgery was performed in quite a comparable proportion of patients. Also, the type of surgery was more or less the same. Looking at the outcomes regarding survival, 18 months, you have nearly 70% after chemotherapy compared to close to 50% after chemoradiation. And the preliminary median survival at the moment, 31 months compared to 17 months. And this tells you that adding radiation is probably not beneficial in the neoadjuvant setting for the patient. Of course, the drawback of this study is that you have no control group with upfront surgery. It's just a comparison between two neoadjuvant protocols. Now coming for the second part to the arteries in borderline resectable pancreatic cancer. We know that the arteries are a problem in pancreatic cancer surgery. You can resect the arteries. We do this in Heidelberg. This is an example where we have put an allograft on the aorta to the hepatic artery when we have resected the celiac axis before, put not on the celiac axis stump, but a little bit higher on the aorta directly. And we all know from the past that arterial resections were not very favorable in the outcome. I just want to quote this review for the SMA resection. 17 patients are included in this review from the literature. This is an example, resection of the SMA end-to-end anastomosis. What we see, the outcome is 11 months median survival. This can be achieved by FOLFIRINOX today. You don't need to operate these patients. This was, from my point of view, the past, published in 2017. Now we have some more recent studies. This is a big series from the US, 111 patients over a nearly 30-year period, pancreatectomy with arterial resections. And I think this is a nice image from this publication. On the aorta, you have a double graft on the hepatic artery and the SMA. This allograft is, of course, something from the vascular surgeons. Regarding the outcomes, this is quite interesting, I think, because you have a comparable morbidity in two time periods that were analyzed, the first 20 years and the last 7 years. And when you see the numbers, this was rarely performed before 2010, more frequently performed after 2010. And the striking point from my point of view is this: mortality when you do this not very often, 30%. Mortality when you increase your caseload and your numbers is 9%. This tells you it's just a learning curve, and then you can offer this to the patients. The second aspect from this study, when you include these patients in a neoadjuvant therapy for the arterial invasion and not go to upfront surgery, this improves your survival significantly. And this is, I think, what we should do at the moment and what we are also performing in Heidelberg at the moment. Now some data and some experiences from Heidelberg. We think still that we should avoid arterial resection in borderline or locally advanced pancreatic cancer, even if a CT scan after FOLFIRINOX looks like this. This does not necessarily require an arterial resection. We have called this the triangle operation. You can go to the OR with this CT scan. You take the frozen sections on your arterial structures here and here. If they are only scar tissue, you can dissect the arteries without resecting that. And then you can clean all of this tissue in between the portal vein, the celiac axis, and the SMA. And therefore, this is so-called triangle, often possible after neoadjuvant treatment. How about the arterials themselves? If we have to resect them, and we could just recently publish our data on arterial management in Heidelberg, we had nearly 200 patients with an arterial resection, and we compared those to 190 patients with the so-called divestment of the artery, which is close to the triangle operation, a little more aggressive even, where you only clean the artery sharply. And you see that these all were locally advanced cancer cases. In the divestment group, all of them were after a neoadjuvant treatment. In the resection group, which was a little bit more historic, approximately 50% had neoadjuvant therapy and then the resection afterwards. And this is an example. Once again, you see in the CT scan, this looks locally advanced and irresectable. Going to the OR, you have a finding like this. You can go on the artery and you can sharply dissect this tumor from the artery. In the end, the artery is clean and this is the tumor specimen. And you do not necessarily resect the artery if you can do it and manage it with a divestment technique. So what is our results from this study? The main result, probably from my point of view, is the learning curve. When you start with arterial resections, you have to consider a high mortality of the patients. This drops when you do these procedures more often. And this is, of course, the same for the divestment. You see that we started the divestment a little later in the time period, and that the mortality of the divestment is comparable to standard pancreatic surgery anyway, 2.3% in the last 5 years. I think this is reasonable. And this tells you neoadjuvant treatment, divestment of the artery, avoid the resection whenever this is possible. What are the prognostic factors? Once again, the regular ones that we know: advanced tumors, advanced lymph nodes, metastasis, of course. And then the resection status is not that relevant anymore. You see, not a significant factor after neoadjuvant therapy. And also the resection itself of the artery is not significant as a risk factor, which means when you have to resect the artery for some technical reason, you should do this. It does not worsen the prognosis of the patient. In all of this cohort, we had a median of 20 months survival and 5-year survival of 12.5%. Anyway, these are data from 2001 to 2019. So a majority of these patients in the beginning did not receive neoadjuvant therapy in the first 10 years. And therefore, I think this can be improved when we do add neoadjuvant therapy regarding the arterial invasion in borderline or locally advanced pancreatic cancer. Now, one question, which from my point of view also is not solved to date, is the impact of adjuvant treatment after neoadjuvant treatment. And this is a retrospective analysis from 520 patients, which the Dutch colleagues performed, was published last year. All of these patients had received at least 2 cycles of FOLFIRINOX neoadjuvant, and all states of resectability were included in this analysis. What you see is, when do we tend to give the patients adjuvant therapy afterwards? When they already had neoadjuvant. This is after increased R1 resection rates or after positive lymph nodes in the pathology in the end. Then you probably say, together with your oncologist, okay, we go for some more adjuvant therapy. What is the outcome of the entire cohort? Exactly the same survival if you have adjuvant therapy or no adjuvant therapy. But the interesting thing from my point of view is the subgroups. And when you look at the lymph node positive subgroups, the ones who still had positive lymph nodes after neoadjuvant treatment, you can double the survival when you give these patients additional adjuvant therapy than if you do not do this. And I think this might be quite interesting to select the right patients for the right chemotherapy afterwards, if you consider this. But I have to admit that these are also only observational retrospective data. Of course, level of evidence is quite low in this setting. The factors for survival in all of these patients was only the positive lymph nodes. This was the only significant factor here. And these were the ones who might benefit from adjuvant therapy after having already had FOLFIRINOX or neoadjuvant therapy before. Now, to summarize this a little bit, and I think this tells us quite well the dilemma. When you look into the NCCN guidelines, I always like to have this in a talk. This is the recommendation of the NCCN, borderline resectable pancreatic cancer. You go for neoadjuvant therapy. Seems quite clear from the flow chart. You look a little further in the patient information in the same website, and you see surgery should only be used as a primary treatment if the tumor can completely remove, and you might have neoadjuvant treatment. I think you cannot put this conflict together in a better way than if you recommend in a flow chart a clear recommendation and tell the patient in the patient information a different thing and say, yes, we can do like this or we can do like that. The same is true for the new guideline in Germany, which is coming up this year. This is the new version of the guidelines for pancreatic cancer. And although this is in German, I will just translate it a little bit. Patients with borderline resectable pancreatic cancer can receive chemotherapy or radiochemotherapy in a neoadjuvant setting. This is a can recommendation. This is not a should or a must recommendation. And the level of evidence is more or less 0, the level of recommendation. So this is not better than the NCCN. And I think this is a good summary of the debate at the moment: borderline, neoadjuvant, or upfront, what should we do? Now, to summarize the topics of my talk, neoadjuvant remains controversial in borderline resectable pancreatic cancer. In venous borderline resectable, we would always go for upfront surgery when technically this is possible. The studies are going on at the moment. For arterial borderline, we would go to neoadjuvant and then exploration in any stable or in any patient with a remission. And of course, when we talk about borderline, we should always not only consider anatomy, but also biology and condition of the patient, as I showed you in the beginning with the IAP definition. The big challenges at the moment, we have little high evidence data on neoadjuvant therapy. We need more RCTs going on with this. How should we select the patient for what therapy? I showed you in the beginning of my talk that we might simply choose the wrong therapy for a patient who does not respond to FOLFIRINOX or who may not respond to other protocols of chemotherapy. We do not really know the role of radiation, if we should do radiation in combination or in a sequence with systemic chemotherapy. And we do know little about the impact of adjuvant therapy after neoadjuvant therapy. We know very good data on adjuvant therapy after upfront resection. So I hope this was the first part of the debate. And now I'm happy to listen to Shailesh, and I think we should discuss afterwards. Thank you very much.
Thank you, Thilo. This was a very clear talk, very nice examples, very nice summary of the literature. We can, of course, move on with Shailesh, and then at the end, we can discuss the questions together. There's already only one question, so we can wait as you suggest. Shailesh, would that be also okay for you?
Yeah, absolutely. I think I enjoyed the talk, and I would like to now do my screen share. There's going to be a little bit of overlap, but just a little bit, and hopefully we will still have a good discussion. So I will start my screen share and begin my talk. Can you see this?
Yes.
You're able to see that? Yeah, you're smiling because you see that I'm having a beer with Thilo. The last time I was in Heidelberg, this was in late 2019. And I was actually there just for the arterial resections. That was a long, lovely evening, Thilo. So I just thought I'll put this up that though this is a discussion, debate, etc., this is right up my sleeve because I'm sure that, I heard your talk. I can see what your thought processes are. I've been in Heidelberg. You're doing so much work. And now let me try and discuss a little bit of surgery and then why I would veer towards neoadjuvant treatment, even for borderline resectable disease. So I started doing pancreatic surgery in 2001, and I was doing more and more over the years, but predominantly resectable pancreatic cancer, negotiating learning curves, experience, gaining in confidence, till you start realizing that what was then being defined as locally advanced tumors, etc., in 2007, a vast majority of them were actually borderline resectable, where one had to resect the vein well. So we started moving on to vein resections around that time, post my time in Heidelberg. But I realized that if I really want to make good surgery, I just need to do the SMA, safeguard the SMA, and then it's possible to start removing the other tumors. So that's why I was there before the EAHPBA in Athens that year, that I spent a week in Heidelberg and enjoyed the time there again. And then we came back, just started doing this as a routine. And what we saw is that we can do this safely. It's oncologically fine. You can work on the artery and things are much better. And then we continued comparing the infracolic with the supracolic approach. And then we also started looking at what the Japanese published in 2015. Now, these are technical aspects which I'm only highlighting because this is also resectable disease. You can call it borderline resectable, but this is resectable. And the Japanese clearly showed you the various levels of mesopancreas dissection, LV1 for a conventional resection, anything involving the vein or more than vein or part of artery was always going to be LV2 and LV3. So I think when we offer surgeries in pancreatic cancer, we are doing a combination of SMA first and LV1, 2, and 3, more often LV2 and 3. This has helped us. Why has it helped us? I get a clear plane, safeguard the SMA, have a tumor hanging on the vein, have the rest of the control. You can do a straightforward type 3 ISGPS vein resection, and you feel that you have done a competent enough job in terms of standard lymphadenectomy template. You've done a complete resection and you have safeguarded the artery. So now you have vein resections of various types. Of course, there are various aspects to it, and I'm discussing only the radiology or the intraoperative mindset of a surgeon. You have a tumor involving the vein, and I get a good plane around the SMA and around the vein, and I will do a resection, and I'm very happy. And since I am a believer that solid tumors, if they are localized, are best treated by surgery, despite advances in chemotherapy and radiotherapy. Specifically in pancreatic cancer, we know that we still don't have excellent chemotherapy and radiotherapy. That's been the challenge which Thilo has also tried to highlight. So I think it's equally important that surgeons focus on finesse and completeness and oncologic radicality. And even in situation B with bigger tumors, I would do the same. And then because we do good surgery, even in situation C, you can actually do it. And this is what Thilo concluded, that if it's vein, for Thilo, it's not borderline resectable, it is resectable. So you can have definitions of NCCN, you can have ISTPS, etc., but it's resectable. But in this case, we should go back and look at what people like Nakao have already documented. You start getting development of collaterals, you start getting far more venous deformities. And these group of patients, despite very good resections, have not done well. Now, this is where the story starts. This is my dedicated pathologist at the Tata Hospital. We still do a lot of periampullary tumors also, and not just pancreatic head cancer, which is about 30% or 1/3 of what you would see in Europe and in America. But of course, in urban India, the numbers of pancreatic cancers and the referrals to my team are on the rise. So you see that with pancreatic head and uncinate process tumors, we have an R1 rate with the same standardized path reporting by the Royal College of Pathologists or the Leeds protocol. You will have 57% patients after an apparently R0 flawless resection where there is tumor positive, R1. But more importantly, even for apparently less aggressive tumors, the lower common bile duct or the cholangiocarcinomas, and even ampullary tumors, you can have 7% of them which are R1 positive. And this is not only for those who were deemed borderline resectable, this is also for those who have just had a conventional Whipple or a pancreatic resection. Despite this, we have tried to look based on the low levels of evidence that is SMA first helping us, and the conclusion of SMA first review or meta-analysis based on the available data, of course, is that you have higher R0 rates and a tendency towards overall survival being better. I'm still not myself sure, though I'm a co-author on this paper, how much of this is based on case selection, how much of this is based on other multimodal forms of treatment, and how much of this is actually due to flawless use of SMA first with high quality surgery. I think it's a bit of everything that comes together to try to tell us that we can improve outcomes of this aggressive cancer. Thilo spoke about this, and we know that for all practical purposes, for all the definitions that we put together, we now know that we clearly do convert the borderline resectables to resectables, and we can do this with better quality surgery as you negotiate your learning curve. So it's the surgeon mindset. The other mindset, of course, is that we have got much improved chemotherapy in the last 10 years. And this has also resulted in many a times being able to convert the locally advanced or the unresectable into the borderline resectable category. This is not applicable to all, but this is certainly applicable to a percentage of patients, as we all pancreatic surgeons have seen in the last 5 years. Thilo has already been a co-author on this paper, and I don't have to go into any details, but the long and short for those who might have missed the initial part of Thilo's talk, we have anatomy, biology, and conditions. So now the story starts of resectable, borderline resectable, and locally advanced. So you should not look only at the BRPC by radiology and surgeon skills. It's important to look at the patient's biology or the tumor's biology. and that can be assessed with the help of PET, CT, tumor markers, etc., as well as the patient's conditional criteria, because you might have situations where it might preclude even major resectional surgery. Now, finally, all oncology surgeons and the oncology world acknowledges that ever since FOLFIRINOX came in 2011 as the best palliative treatment or palliative chemo, it's graduated to the point that it's clearly perhaps the best adjuvant treatment for pancreas cancer. And you see the reason: because of the modified FOLFIRINOX, the median overall survival has gone to 54 months as compared to something like 35 months in the gemcitabine group. So something is working in pancreas cancer. And what are the lessons that I would like to take from these two, from this study? Two specific lessons. The number one is that adjuvant FOLFIRINOX did show a biological effect, indicating that even after upfront resection, there is disease on which chemotherapy can work, will work, or likely to work. That's what we have seen. The second lesson, which is important for surgeons, especially in a group that is starting to work with med-oncs and radiation oncologists, even after apparently curative surgery, there is an early follow-up, as you can see right at the beginning, in survival due to death from disease progression in patients treated with upfront surgery. I'm sure even Thilo would see this and clearly agree with me that we have a problem because we are essentially dealing with a disease which is a systemic disease to begin, perhaps years before they present to us for pancreatic cancer surgery. That is not to say that adjuvant chemotherapy doesn't work. It clearly works, as has been shown by this nice slide. Last week, Jörg Klief, my other friend from Switzerland and later in Heidelberg, was talking to an Indian audience. And I was just sharing a nice picture of the World Pancreas Forum with Jörg yesterday, just the way I shared a picture with Thilo just now when we were in Switzerland. And I told Jörg that I will be using a couple of his slides. So this is what you can clearly see what happens, is that if you complete all cycles of adjuvant chemotherapy, patients are doing well. So there is no question that if you have clear resectable disease, tumor marker is within acceptable limits, patient is in good biological condition, you have a high chance of getting an R0 resection, I would do an upfront surgery as long as I can give safe outcomes and ensure that they complete perhaps 6 cycles of adjuvant chemotherapy. I agree, there is a role for that. But the ground reality outside of centers of excellence, especially when you start getting in data, is that up to 50% or more patients fail to receive adjuvant treatment. We all know and we all acknowledge that we have 20 to 25% in the best of hands post-operative complications. But I also am aware that you need not start chemo not only for 8 weeks after recovery, you can even wait for up to 12 weeks, as the SPAC paper in JAMA showed some time back. You can wait for up to 3 months and then start adjuvant. That's the good part. But you still have a large number of patients not getting adjuvant because of early mets, poor performance status, associated comorbidities, and other factors. This is the ground reality. We can't ignore this. This makes us move and start thinking about the possibility that should we give something before we do surgery, which has a 25% morbidity and a 3% mortality. What should we do? So this is the data. Obviously, the data is still not great because we have 8 prospective studies in this. We have collected a total of 313 patients. You have an impressive resection rate, but it also means that perhaps 20% or more do not reach the OR. And I acknowledge again that surgery, perhaps in this multimodal world, still remains a dominant treatment option. But the R0 resection rate in those who get a neoadjuvant FOLFIRINOX is close to 84%, and a median survival for BRPC is a very acceptable, respectable 22.2 months as well. And this is what you can clearly see, the pooled data that shows us how the survival rate drops over a period of time. We also have some other good levels of evidence, and this is from Mikiaki Uno from Japan. Excellent work. I've been following his work for some time. And this is phase 2, phase 3 trial, neoadjuvant chemo with GEM and S1 versus upfront for resectable pancreas cancer, mind you, not for BRPC. And they have compared 182 patients with 180 patients. Both arms, S1 adjuvant for 6 months was what they gave, and 2 cycles of 14 days gemcitabine plus S1. And you can see here that grade 3, grade 4 adverse events, 72%, but there is a difference in overall survival, which is impressive, 36.7 versus 26.6. But there was no difference in resection rates, R0 rates, and morbidity. So this is one study. And then we also have something published last year, neoadjuvant S1 with concurrent chemorad, followed by surgery for BRPC, phase 2 study. And again, you can see that R0 resection rate is 63% and median survival 30.8 months. So you have data which is clearly coming in more and more, which will make us think and which will make us rethink. Thilo presented this, and we all have heard this virtually this time very recently, last month in ASCO. And yes, it's a setback for the radiotherapy arm. So we don't have good levels of evidence for radiotherapy. We have a trial at the Tata Memorial, the NEVAS trial, which is a single center trial, will take some time. So we will continue to evaluate radiotherapy in the form of SBRT, but presently it seems that FOLFIRINOX is doing things. 18 months survival, as Thilo said, was the endpoint, and you can see the difference between arm A and arm B. And there's also a difference in the resected 18-month survival group between arm A and arm B. This is some of the older data. And again, here is an overlap with what Thilo spoke. Yes, it is the first RCT on oncologic benefits, but it has problems, and there are certain cons of this trial and shortcomings, both in terms of the small numbers amongst other factors. But yes, there was a difference in 2-year survival, also a difference in the R0 resections. Surgeons always focus on R0, and we can see that neoadjuvant seems to be doing something when it comes to an R0 resection. Retrospective data, and I'm deliberately going back to try and also show other continents. And here you can see that a SPAT complete response following neoadjuvant chemorad associated with prolonged survival in patients with pancreas cancer. This is from Chris Wolfgang. And median overall survival, 27 months. You can see the difference in the Kaplan-Meiers between the PAT-CR versus the non-PAT-CR. So PAT-CR, negative lymph node status, and neoadjuvant FOLFIRINOX, independent predictors of overall survival is what this particular paper has tried to convey. And this is my friend Thilo. And this is again very good because I know this paper very well. And what he has clearly shown is that neoadjuvant therapy results in downstaging and resectability in 30 to 60% of what I would call a mixed group of patients. For them in Heidelberg, I have seen that many a times they would club resectable and borderline resectable as resectable. And here there are variations to the borderline resectable. So in this group, there is borderline resectable as well as locally advanced. And then they have looked at this and clearly shown impressive data where they have moved on to do chemotherapy or neoadjuvant therapy, and yet shown that in excellent hands, morbidity, mortality, and resection is no different in terms of outcomes. Thanks to that kind of confidence, our own confidence over the last 10 years, and the work in Heidelberg, where I've been mentored and trained a fair bit We have continued our own journey where we would do multivisceral, vascular, post-chemotherapy, post-radiotherapy, but sometimes upfront as well, if we feel that we are selecting the right patients by the ABC classification. And so moving on, this is what we would also see as Thilo has shown. And then when these patients are treated with a combination of chemotherapy and or chemoradiotherapy, you would have situations where you would do a complete resection, a celiac axis resection, but the gastroduodenal artery was preserved. And since it was fine, we didn't have to reconstruct. Otherwise, we would reconstruct again from the aorta with a hepatic artery graft. So there would be situations where we would do a modified Appleby and we would get away for this kind of a tumor, which on first situation is clearly unresectable advanced pancreatic cancer. This lady is doing well, incidentally, for over a year and a half after neoadjuvant and an artery resection like a celiac axis resection. This is our data, and even in the COVID year, we have done well as a dedicated GI unit and as a dedicated oncology hospital, that we could continue our services and do a fair bit of pancreatic resections. We've published our work of about 1,200 cases, the highlight being that we've done more than 700 in the last few years. But actually, that's not what I want to show you. What I want to show you is something on which we are currently working on, that majority of these 201 cases have come up in the last 5 years. And you will see what we actually do. Forget the debate and forget whether I speak for neoadjuvant or whether Thilo speaks for adjuvant. We would have a number of patients who are treated upfront for what is defined as BRPC. We would have neoadjuvant therapy given as well. And we will also document the number of patients who've not got an exploration. I know that the data is different elsewhere, but this is the ground reality of what I see in my practice in terms of disease progression, refusing surgery or treatment due to quality of life or other issues, defaulting from treatment, performance status objectively going down, and patients even dying during or before getting the intended treatment. So at the end of it, yes, we would get an R0 resection in about 62% of patients. And yet, this is where Thilo will again say, I told you so, that the median survival in the intention to treat group, there is no difference when it comes to statistical significance, though there seems to be some difference as far as median overall survival is concerned, but that's not the case for disease-free and median overall. It's not statistically significant difference that you can see from our cases of borderline resectable disease. This also brings me towards the end of my talk to trying to integrate that we need to integrate something more beyond surgery, chemo, and radiotherapy. And you will see that this is very close and this will be around the corner. And this is one of the papers which clearly shows that if you see this, you have this S2, S100, A2, and A4. If they are positive, what's happening? And if they are negative, how patients continue to do much better. So something which Thilo was alluding to as to we don't know which kind of chemotherapy to be given in which patient. I think this will also gradually change. We will get superior chemotherapy than what we have, the way we have made progress in the last 10 years. We will integrate precision oncology as well. And then we would continue doing good quality surgery. And then we would go ahead in offering improved outcomes after having a borderline resectable pancreatic disease. So here I say that though I spoke in favor of a lot of data for neoadjuvant, this is the ground reality and the jury is still out in terms of levels of evidence. And for those who are watching, you can see that what's the recommended management of this excellent paper published recently, that for resectable disease, you can have surgical resection, 6 months of post-operative chemo, or pre-operative chemo with or without chemo rad, then surgical resection and post-operative chemo. What surgeons and multidisciplinary teams need to understand is that even in the resectable space, the role of chemo has somewhat come in. But I'm not by any chance trying to say that everything needs to be treated by neoadjuvant. I, for one, I'm still not a convinced believer when it comes to resectable disease with low risk features. I think we would resect and then go ahead with adjuvant chemo. And exactly for borderline resectable disease, they say same as for resectable. Thilo spoke about the subgroup analysis of the PreOpanc study with some improvement with preoperative chemo and chemo-rad, but those numbers were not the kind of numbers that Thilo showed with other trials as well. So you clearly have a situation where for locally advanced, I think there is no debate. Everyone would go ahead with neoadjuvant treatment, and those small percent of patients who really respond, you can operate or do divestment, and then you will get away in locally advanced disease. So this is going to be my last slide. Apart from thanking my whole team at the Tata Memorial for the work that I have presented, it's all due to the team that I've been fortunate to be associated with. With this, I'll stop because I'm sure we have, there's more data that I can present, but I think it's important that we have a good discussion and then carry on with this talk. Thank you.
Thank you, Shailesh, for this excellent and precise talk. Now, if that would be okay for everybody, I would like to move on with the questions from the floor.
Sure.
The first question is from Professor Ibish from Istanbul University. He is asking, how was the prognosis of the patient you mentioned? This is for you, Thilo. At the beginning of your presentation, we heard that in Heidelberg, such patients, in parentheses, locally advanced or irresectable, will go to OR following neoadjuvant chemotherapy, no matter how it seems in CT scans. Is it right? And then comes the thanking. I think the question refers to the patient. Yeah.
Yes, actually, we operated this patient mid of January, so I cannot really tell about the prognosis at the moment. He went home on day 18 without a big complication. Fortunately, we were lucky because in this type of operation, you always also have to expect some morbidity, but he didn't, so I was really happy about that. And I mean, now he is R0 after neoadjuvant, and he has an N0 situation, so probably the prognosis is quite good. Anyway, this is of course locally advanced, what I showed you there. And yes, you are right. We tried to take all of these patients to the OR. From my point of view, the limiting factor, if you do not do an exploration, is basically the veins. The arteries are mostly not that much of a problem. It's mostly about the veins. If you have a superior mesenteric vein infiltration very far in the meso of the jejunum, or if you have a collateralization, this is what limits you technically, not the arteries themselves, I think, in most of the patients. So this would be an exclusion criteria for exploration. If you think the vein is not reconstructible. About the arteries, we would always try to check through the frozen section and then decide, can we do a divestment or can we do an arterial resection? And of course, in a 48-year-old patient, we would do this. If this patient had been 80, I wouldn't have done this operation. Sure. This is about the selection once again.
Thilo, pertinently, would you please comment on the issue of creating intractable diarrhea due to the resection of the sympathetic nervous fibers around the SMA? When you do a complete resection, how serious of a problem is that for you?
Well, this is a problem, and this is some type of the morbidity the patient will experience. This is on one hand the diarrhea, and on the second hand the lymphatic leaks that you may have. The lymphatic leaks you can treat quite well, I think, with a diet and then with lymphangiography if necessary. This will resolve within 2 or 3 weeks. The diarrhea sometimes is a major problem. I think in approximately 10 to 15% a severe problem. And of course, the diarrhea is some symptomatic treatment afterwards. Most of the patients after 8 weeks, from our experience, when they come back to the outpatient department, are recovered again from the diarrhea, but we do have some patients that are continuously on parenteral nutrition because they just don't get along with the diarrhea. This is a fact that is true, and this might happen from time to time, but the percentage is not that high.
Okay, thank you. So the next question is from Professor Çoker. He is asking, I have to translate the questions in Turkish. So a patient receives first an neoadjuvant therapy and then goes into the OR, and you cannot achieve an R0 resection, or the final pathology reveals an R1 resection. Would you please compare and comment on this in comparison to upfront surgery and adjuvant therapy afterwards? So you start with neoadjuvant, you resect the patient, but the situation is an R1 situation. So if you compare a group like this with standard upfront surgery plus adjuvant chemotherapy, what is the survival benefit in these groups?
Is it for me?
I think it is for you both. He didn't
ask. So I take it. I think it's a it's a difficult situation to have because we don't have very clear data on that. That's what you saw that has come out from both the presentations that we know. But in this patient, there was neoadjuvant chemo given, and R1 is only one aspect of it. One would actually need to look at so many other factors in terms of response to the chemo given as a neoadjuvant treatment or radio, whatever was given. And then follow it up, of course, because you have R1, you will obviously acknowledge, even if it's R0, a high proportion of patients who have been given neoadjuvant would get adjuvant treatment as well. But I don't think we really have good data to compare upfront surgery adjuvant versus neoadjuvant and R1 and then compare. I think we are comparing two different groups or apples and oranges in terms of tumors, locations, so on and so forth.
Any comments from your side, Thilo?
I absolutely agree with this. This brings us a little bit back to the topic I mentioned, who should receive adjuvant after neoadjuvant. We know that after neoadjuvant, the resection margin doesn't seem to have that strong influence anymore from the retrospective data from this Dutch analysis I showed you. The only factor was the positive lymph nodes, but of course, retrospective data. And the R status seems to lose a little bit of the importance as an independent prognostic factor. Anyway, we should discuss adding adjuvant treatment again in this patient, but this remains individual, I think, and how much chemotherapy a patient can tolerate in the end.
Okay, thank you. So the next question is from Professor Ibish from Istanbul University to Professor Shrikande. Consider, Shailesh, please, an uncinate process tumor infiltrating SMA and celiac trunk circumferentially. At the time of diagnosis, accompanying duodenal obstruction is present. Palliative gastrojejunostomy is performed. Biopsy of lymph node 8A revealed pancreatic cancer metastasis. She received FOLFIRINOX radiotherapy plus capecitabine and FOLFIRINOX again, so a complex protocol, I guess. At the end, no activity in PET CT scan. That's, I assume, no PET positivity is meant, but anatomically obvious response, but SMA and celiac trunk encasement is still persistent. No elevated CA19-9 after 2 years, no distant metastasis. The patient is 43 years old, in a good condition. Would you explore a patient like this? What would you suggest to such a patient? And thanks again for being with us.
Yeah, so I think clearly this is the kind of case where the ABC applies. We have challenges with anatomy, but we are clearly in a good way as far as the B and C is concerned. So now as a surgeon, I would focus back on the A, and that's the anatomy. And we just heard from Thilo, they clearly have more experience with arterial resections. We've begun our journey on arterial resections more recently. But the divestment story is something which is clearly more exciting to us, and we have been doing this for a while now. We know that vast majority of pancreatic cancers do not infiltrate the artery, they can be shelled out. So a patient who has had a good response to chemo and radio, my first thought process is not to offer a resection to the celiac axis or to the SMA, but still attempt an operation to take it out completely. One. Of course, would these operations have a higher risk of complications and mortality? Yes, these patients will have to be counseled for more risk of complications, including a mortality and a total pancreatectomy and the problems that can happen with a total pancreatectomy. But why would I do all this in a patient who is living well for 2 years, good response to CA19-9, young patient, good quality of life? Simply because we know that chemotherapy and radiotherapy is good for control. We still are nowhere near to offering a cure with non-surgical means. So it would be impossible to know whether the tissue inside is alive or dead as far as pancreas cancer is concerned. But certainly a patient who has withstood this kind of treatment is nutritionally good. The 360 degrees would not completely make me back out. We saw the kind of pictures that the TrueT study from Mayo Clinic has shown. I don't have experience of simultaneous replacement of celiac axis and SMA. Maybe Thilo would be the person who can agree and answer that. Isolated celiac axis resection, fine. Isolated SMA resection, fine. But a number of them take out the tumor without resecting the artery is my thought process.
Thilo, would you also please comment on this patient?
Yes, I absolutely agree with Shailesh. I would also offer surgery to this patient. And I mean, a little bit, it is like the case I presented in the beginning of my talk, where we did resection of both arteries and portal vein. And technically, this was feasible. And as I told you, fortunately, we did not have complications in this patient. But once again, I agree with Shailesh. The patient has to be informed about the extent of this operation and also about the danger of the operation, that there might be severe and also life-threatening complications. But still, after 2 years, chemotherapy will sometimes fail to control the tumor, and the only chance to offer a longer survival is surgery, from my point of view.
And if I may add, Mert, to the same question, which is a kind of part of our talk, I think today the debate is not about the role of surgery and chemo and radio. The bigger debate is how do you sequence what and when, and what are the outcomes of individual surgeons and units. The key is that the patient should get the maximum and best possible chemo and the best possible surgery. Radio, the data is still coming, but they must get both in equal measure and get it well. Now, how you sequence it and how you plan is every individual unit rather than pooled data from all over the world, which confuses things.
I completely agree with you. There was one question from Professor Özden. You touched actually that point with your literature from Uno and Takahashi about the usage of S1 in the neoadjuvant setting. Is that a common practice also in India? And Thilo, would you please comment on the issue of using S1? Is it a practice in Germany?
So in India, there are some efforts to try and get S1 by some of the Indian pharmaceuticals, and they are available, not routinely, not easily, but they are now available. Having said that, me or my medical oncologist or our team in Tata so far has no experience with using S1.
Well, in Germany, S1 is not used at all because I think it's only effective in Asian people, as far as I know. And I think it doesn't even have a license in Germany.
I always heard the same urban legend, but even if it doesn't have a license in Germany, I don't know who tested S1 and saw that there was no response in the West. So I think that is still something to be explored.
I'm not sure if it was ever tested.
I know the story about that for a very long time, but I also, my information is restricted to that sentence as well. So the next question is, I think, for both of you from Zonguldak, from Dr. Günay. Is there any difference in intra-abdominal adhesions in patients, those who received neoadjuvant chemotherapy versus neoadjuvant chemoradiation? Does radiation therapy generate adhesions? And this is from Dr. Günay.
So my take on the matter is actually neoadjuvant radiation perhaps makes things easy. I do not feel that it makes it difficult. I know these dissections are a little bit tedious, and we are used to normal healthy tissues as cancer surgeons, because the principle of oncology is you work in normal anatomy and take the tumor out. So that's not possible with chemo and with radio, but I think it actually makes things reasonably acceptable. There are no exceptionally extra new adhesions due to radiation. You might have given radiation because of multi-organ involvement. So that dissection is a little bit difficult and taxing, but by no means for an expert surgeon, this is something difficult, I would not say. And with chemo, you know, surgeons have got trained with chemo radiotherapy with rectal cancer in the last decade and a half. I'm completely used to perioperative chemotherapy for gastric cancer. So it's not a problem to have chemotherapy before surgery.
That's my experience as well. I think adhesions never after radiation or chemotherapy. The only thing that I often notice after radiation is that you do have some kind of lymphatic congestion, that everything is very lymphatic, the tissue is very swollen, and you cut in and you see the lymph leaks already coming out. This is my personal experience. I think it's much worse if somebody had an exploration with a double bypass before and was not resected, then you have the adhesions, but not from the radiotherapy or the chemotherapy.
And if I may add, Mert, to what Thilo was saying, the other thing, I just try to make a conscious decision when it comes to the anastomosis, both of the pancreas and the bile duct. If you have a radiated field, just make sure that you are trying to do an anastomosis in as vascular an area as possible. Things might look very dry and clean thanks to the radiation, but I don't want things to look very clean on the pancreas cut margin and the bile duct, because I will have this worry of the healing issues. So I rather have a bleeding cut pancreas and a bleeding bile duct in a radiated field. Just standard.
Yeah, that's experience talking. So the next question is a direct question to Thilo about the divestment and the triangle operation. So when you're choosing patients for the divestment, are you using any radiological criteria? The question is from Professor Tüzüner from Ankara.
No, the divestment you can basically not choose before the operation. I think you go to the OR after neoadjuvant therapy. The CT scan tells you there is some soft tissue. Yes, tumor, you don't know. And then you try to do the divestment. If the divestment works, it's fine. If you get into this layer, you notice that you get into this layer and can take it off. The problem about the divestment is once you have a problem and the artery has an injury, you must be ready to do an arterial reconstruction. So the divestment is the first step. It often works. If it doesn't work, you have to stop either before you get into trouble, or you have to be ready to reconstruct the artery if ever necessary.
That is correct. So there is a question, actually two questions from an anonymous attendee. The first question is, if you perform upfront surgery without neoadjuvant therapy and find arterial invasion intraoperatively, would you stop surgery and start then neoadjuvant therapy, if you might say, or resect artery and go for adjuvant therapy? That is the first question on both. Thilo, maybe we can start with you. Or, yeah.
Yeah, so for me, I think if there is an arterial invasion, I would rather try to do neoadjuvant. But I don't want to sound arrogant, but I'm also quite glad to tell you that this situation should be less, because with the kind of radiology we have now, it's always possible to study very closely the possibility of an arterial invasion preoperatively. And I would rather not land in a situation where it's an intraoperative local discovery and then back out. But if you do land in this situation, I would stop surgery. If there is no need for any bypass, I would just back out quickly and then put them onto neoadjuvant therapy and then reassess them, is the first question. And the second question, do you explore? Oh, I'm sorry.
Yet asked. Maybe we can get the comment of Tito on the matter. And
okay, so I would do the same. If I have upfront surgery, arterial involvement, I would stop and hopefully stop before the exploration was too extensive and go for neoadjuvant and then re-explore the patient. Upfront arterial resection is what I showed you, what we did some 15 years ago, probably. Now I think we believe in neoadjuvant for arterial involvement, yes.
So the second question from the same person is, do you explore every patient after neoadjuvant therapy, regardless of the local situation on imaging?
So I won't explore every patient. I'll be quite conservative, especially if we are looking at the arteries. With the veins, I will be less conservative, very clearly. But with the arteries, I'll be conservative. Sometimes I would, many a times I may not explore. That's what I showed in our data as well.
Yes, Tilo?
It's a little bit like I commented on before. From my point of view, I would stop or not go for exploration, a little bit in contrast to what Shailesh said. If the veins look very difficult, if you think that the veins are a problem, for the arteries, I would be more confident that I can take it off the artery or can reconstruct the artery. I think the veins are sometimes more difficult. And if the images show you collaterals, transformation of the portal vein, things like that, no exploration. If it shows you a reconstructible vein, I would go for exploration, yes.
Okay, so the next question is from Dr. Vani. What's the role of frozen section after neoadjuvant chemotherapy? How reliable? And the second question asked by him is that, are the leak rates really favorable?
So I can take that. I think you can have reliable frozen section. You have dedicated pathologists who will assess the response to chemotherapy. And it's not that they just can't see the situation intraoperatively if you need a frozen section after neoadjuvant chemotherapy. And I don't think the leak rates are favorable or unfavorable. We have critically tried to look at data, and I don't think there is any big difference. I know there is a subjective feel that post-chemotherapy in pancreatic cancer, the leak rates are less. But I've always argued this for a long time, that for ampullary and neuroendocrine tumors, the pancreas is soft. For lower common bile duct tumors, the pancreas is soft. There is no ductal dilatation. There is no associated chronic pancreatitis. These resections are easy, but these reconstructions are dangerous. On the other hand, ever since the meta-analysis by Bartoli in 1991, we know very well that both for chronic pancreatitis and pancreatic head cancer, the leak rates of pancreatic anastomosis are anyway low. So here we have a large tumor, perhaps with associated desmoplasia and chronic pancreatitis changes, who have been given neoadjuvant because they were deemed perhaps borderline resectable. So the neoadjuvant chemo gets the credit for the low fistula rates. I don't think so. I think it's anatomy and it's tumor pathology. I don't know what Thilo has to say to my thoughts.
Well, regarding the frozen section, I would say it's accurate after neoadjuvant as it is in upfront surgery. I think the pathologists are right in some 98% of the cases. From my experience, it is very rare that afterwards they say, intraoperatively, we told you no tumor, and now in the final pathology, the frozen section was reevaluated or something, and we have tumor. I have no problem with frozen section after neoadjuvant. And the leak rates, I think they are similar or maybe lower after neoadjuvant. I think there's this nice paper from the Boston group in JAMA surgery where they show that pancreatic fistulas after neoadjuvant are reduced. And this is probably somehow related to the pancreas, which is congested by the tumor anyway, and which is then by radiotherapy or chemotherapy even more affected in terms of fibrosis, fibrotic tissue. So I think there is no fear that neoadjuvant increases your morbidity.
Next question is from Dr. Patankar. What percentage of patients remain inoperable in spite of neoadjuvant radiotherapy? Probably radiochemotherapy is meant.
So I think that answer is variable for two types of tumors. One is the borderline resectable group and the other is the locally advanced group. I would feel that for the borderline resectable group, you can get I won't say they remain inoperable, because borderline resectable may be operable right at the beginning. And then you will have about 30% who will drop out. In the work that I presented, we have 42% which has not come on the operation table. But having said that, I would say 60 to 70% would get an operation if you compare data across centers. But when it comes to neoadjuvant for truly inoperable arterial involved locally advanced pancreatic cancer, I think the number comes lower down, because everything is not Heidelberg or Thilo's or Marcus Buechler's experience. I would feel that the figure would be about 30%. But Thilo, I would like to hear your thoughts to this question.
Yes, Shailesh, thank you. I think this is just a matter of attitude from you as a surgeon. If you are more aggressive to do this, if you say, yes, I want to do arterial resections or things like that, then you can increase your rate to 50, 60%, probably, as we have also published some years ago.
Yes.
But of course, if you don't feel comfortable with this, if you think that is dangerous and that you cannot handle this, then you are approximately around 30%. And I think the dropout rate, you showed your data from Tata Memorial, which is approximately 40%, you said. The dropout under neoadjuvant, these are the ones who advance, who get metastasis under neoadjuvant. And I think overall the patients, the dropout rate might be around 30%, 25%, something. And this brings us back to the problem of the selection for the right therapy. If you give them FOLFIRINOX or if you give them gemcitabine, maybe you would have benefit if you had chosen the other protocol.
Sure.
We just don't know in many patients.
Yeah, but just one question, Thilo. I completely agree with what you said in terms of the attitude, and one can improve the arterial resection rates, etc. But if you look at the whole data, which is published all over the world, would you agree that the general thinking is that for locally advanced, not borderline resectable, the conversion, how much would be the conversion for true locally advanced pancreatic cancer after chemotherapy to get a resection in terms of a figure?
I think for truly locally advanced, the conversion rate at the moment will be approximately 25%.
Mm-hmm. Yeah.
I mean, in the Heidelberg data that I mentioned, there were also there were also borderlines, and there was some metastatic who vanished, the metastasis went away, but they were easily resectable locally. So this brings us to this 60% resectability, but the truly locally advanced ones, maybe 25%, 20%, something like that.
I'm sure that answers all the questions raised by this question. Thank you.
True. So a technical question, what type of vascular graft do you use for SMA reconstruction, if you have to use one?
I would ask Thilo to take this more than we do, because we have done only primary reconstructions and we have done PTFE grafts. But I'm sure he has more options for the SMA reposition.
Well, regarding the SMA, from my experience, you can often do it without a graft.
Yeah.
Because you need a big diameter on both sides. And this length, where you still have a big diameter towards the small bowel, is usually 3 centimeters, 4 centimeters. You have mobilized all of the intestine, and you can just pull it up and do an end-to-end anastomosis. If you do need an arterial graft, we sometimes use allografts from donors, which you can choose. We have also used PTFE grafts, but not very good experience with that. So I would try to avoid SMA graft if possible. And if you do need it, allograft is a possibility. You can also use veins, of course, but then you have to prepare the vein before. of course, and use the vein for that.
Tilio, are you afraid of the tension that might be applied on your anastomosis after you circumferentially dissect the small bowel root and then also resect some segment of the artery? You know, for any kind of vascular reconstruction, you wouldn't like to have some tension on it, but there the small bowel is practically hanging on your anastomosis. How would you prevent this overstretching? Would you somehow suture it to somewhere?
No,
do you take any measures?
I would not fix the small bowel anywhere. I think this is some kind of physiology that has to work by itself. If you have mobilized all of the small bowel and put it a bit upwards and put it together again, it's the same as for the portal vein. I have never experienced that a portal vein tears after the operation because of tension. I cannot explain it. Maybe probably the bowel just adapts to that in some way. But I think this is too mechanical thinking. If the patient stands up, the bowel falls down. But I have not seen it. I cannot only tell.
But,
Shailesh, what would you think?
The thought process is right, but I have a different answer to what Thilo was saying. He's right that I think the body adapts in a way that things don't, the worst of our thinking is not what gets translated when the patient is in the ward and walking, etc. But I also feel that when we do these operations, we take so much of care intraoperatively, because you just know that if things are going to go wrong with an anastomosis like this, it's a disaster post-operatively after you close the patient. So I think everyone takes that care in terms of more than adequate mobilization with the cattle brush, making sure that it's not lax, but it's precise, making sure there is not too much of tension. If there is a doubt, this week we have had a situation of an SMV where we reconstructed, then we took a break and things looked good. And then after the break, the bowel is becoming big, chaos. A right hemicolectomy added for a young patient with a neuroendocrine tumor with PRRT given before, 20-year-old man, and a large tumor. But then finally, we decided to redo it. We redid it, but it was not looking good again. Then the peritoneal patch, then preparing a vein, and then finally doing it to our satisfaction. So yes, there were 2 episodes of bowel congestion. There was a right hemicolectomy added, but finally on table, everything in a straight line, no tension on the anastomosis, liver mobilized down for whatever it's worth, and the entire small bowel moved up. Patient out of the ICU in 36 hours is doing fine. So I think we all take a lot of care intra-op to have this situation. Now the SMA artery and coming under tension, when you said, Thilo, the whole small bowel moves up and you can join. Actually, I have a question for you. How much can you do for a primary end-to-end anastomosis in terms of loss of length in your experience?
Well, I think for the SMA, the loss of length, you can do very good 3 centimeters. This is fine.
3. Okay.
3.
That's good.
If you have more than that, you will have a problem, because one thing is that you go into the branches of the SMA already, which is horrible to reconstruct.
Yeah.
Or the other option to reconstruct is that you take out the left pancreas, preserving the splenic artery, and then you transpose the splenic artery to the SMA.
Yeah.
That's another option.
Yeah.
Okay, so is there a difference in terms of survival and clinical outcomes between R1 vascular and R1 parenchymal resections, considering borderline resectable pancreatic cancer?
I don't really think so. It's not very clear. It's more a function of location and more a function of lack of chemoresponsiveness in case you have done neoadjuvant, or incomplete surgery. But otherwise, it doesn't make a difference. R1 is R1, if you ask me.
I think the position on the neck or vascular is not that decisive, as Shailesh said. Maybe the number of R1 positions might make a difference. There are some data from the ASPEC studies that this sums up to a poorer prognosis when you have 2, 3, 4 positive margins.
Yeah.
But one positive margin is probably not that decisive on which margin you have it.
Mm-hmm.
So the next question, what do you think about chemotherapy effect on epitumoral area? Do you think is there any difference on effectivity for local or distant metastasis comparing neoadjuvant and adjuvant settings? For both of you, from Dr. Maria. Shall I repeat the question, or?
No, I'm reading it. I'm reading it, comparing neoadjuvant. I'm just trying to understand the question. On epitumoral area, do you think there is any difference on effectivity for local or distant mets comparing? So to the best of my knowledge, I will answer the second part first. Do you think there is any difference on effectivity for local or distant mets comparing neoadjuvant and adjuvant? I don't think there is any difference. If there are people who are responding well, they are responding well. And if they are not responding well, they are not responding well, based on our existing knowledge of chemotherapy, the way it is used, which has clear limitations, as we discussed in our talks. Now, what do you think about chemotherapy effect on epitumoral area? So I think this is a little bit of work on which Mert himself has worked. We know that we have tried to see whether we can do something about the desmoplasia, but trying to deal with that has actually resulted in bad outcomes, because we know that pancreatic cancer grows in a hypoxic environment, and that penetration of chemotherapy has been widely considered to be a problem. And so people have tried to see how the area around the tumor can be made more permeable. But in trying to do that, we have ended up getting worse results in some of the trials which have tried to do this. So that's what I think, that the chemotherapy which is working, but specifically on epitumoral area, I'm not sure I have the answer. I don't know what Thilo has to say to these questions.
Well, yes, to my knowledge, the chemotherapy itself on the epitumoral area, which means the desmoplastic stroma, is not effective. There were some approaches to target the stroma itself, but clinically not really successful. So I don't know that this has been really addressed in the meantime with an effective approach. Yeah. And the effectivity for local or distant metastasis, neoadjuvant or adjuvant, I don't know. This would imply that there is some difference because of the tumor load, that you have reduced the tumor load and then chemotherapy can act more effectively. But to my knowledge, there are no studies that have really compared this in a good way. This brings us to what Shailesh showed in his talk, what you leave behind, what Chris Wolfgang's group always is interested in, the micrometastasis after the resection and so on. And of course, if you have very little tumor load, chemotherapy might be more effective. However, you might also have a distant spread that you can target before. So this is a very difficult question, I think, if it's more effective before or after.
So let's move on, considering also our time. There is a question from Professor Uz from Izmir regarding borderline resectable PDAC. Do you have any patients losing their chance of operability during the neoadjuvant treatment? If you have, what is the average? What is the percentage of it? So patients that turn out to be inoperable or progress from borderline to inoperable during neoadjuvant.
Yeah, so the question is in terms of survival?
No, the percentage is asked. I mean, you start with neoadjuvant in a borderline resectable situation and there is progression of disease. What is the percentage of it?
Yeah, so this would be about 30 to 40%. I mean, it's in our experience. World experience would perhaps be a little bit less. It might be 20 to 30%, but they will progress. That's one of the counter arguments against neoadjuvant chemotherapy. That's one of the existing counter arguments.
Yes, I think the rates in the literature that are reported are somewhere around 20%, as Shailesh said. And as he also said, this is the argument against neoadjuvant, because these people have been denied the chance for surgery, you could argue. Yeah, and if they had been operated upfront and they were lucky, they had survived 54 months with FOLFIRINOX afterwards, and they had maybe a non-effective chemotherapy and progressed, and then everything was not resectable anymore.
So the last three questions, and I have one final question from myself. The first one from the audience, from Dr. Saraçoğlu: which approach do you choose for SMA first surgery, medial, uncinate, etc.?
So the best thing is to look at the British Journal of Surgery publication. And this is the 2012 publication, which is the 2012 publication. And this publication clearly highlights the advantages of the different approaches, whether it's the medial, whether it's the infracolic, whether it's the superior, and this would all depend on the location of the tumor. Having said that, I think it's not that you choose one approach for one surgery. I might use all approaches for the same tumor just to make my dissection easier. Finally, you go from what is known to the unknown, or from what is simple to the difficult part at the end. So I think in a conventional Cocker maneuver, we do the posterior SMA first exposure as much as possible whenever we can, and then we decide on the medial or the uncinate or the infracolic ligament of Treitz approach. So it's variable.
So during the arterial reconstruction, do you have any preference for graft? And a relevant question, if you are resecting SMA and hepatic artery reconstruction somehow is needed, would you go for a total pancreatectomy for the security of these arterial anastomoses? So any preferences for grafts?
I think we have talked about the grafts already before. Yes. I would try to do it with a replacement end-to-end or with a graft from a donor, for example. And regarding total pancreatectomy, yes, I would do total pancreatectomy whenever I have the feeling that the anastomosis with the pancreas has a risk of fistula. Then I would be very liberal to take out the pancreas, especially if I like to have the splenic vein, the splenic artery, for example. This is another argument to take out the pancreas and preserve the artery. I would not risk a pancreatic fistula in a major arterial anastomosis.
So from Dr. Ünalp, in rare cases, we face total fat replacement of the tumor after neoadjuvant treatment. Would you still proceed to the surgery? Total fat replacement is probably some radiological finding is meant.
No, I didn't get the question exactly, Ahmad.
So I think you can also read it on your thing. I mean, in rare cases, we face total fat replacement of the tumor after neoadjuvant treatment. Would you still proceed to the surgery? I think yes. He's talking about some radiological finding.
Yeah, I think so. Because if you have clearly seen the pancreas before and you've had neoadjuvant treatment, and if there is an indication for the surgery, we would still take it out. It's worth it. This is very much like the liver metastasis and colorectal liver mets after chemotherapy and after bevacizumab, etc. We know that majority of them might be completely gone as far as tumor is concerned, but they recur. So I think we need to take it out.
So one final question. Yeah, Tilo, please go ahead.
No,
sorry.
Just because you don't know what is in behind, and the tumor is usually proven before start of neoadjuvant therapy. So you know this patient had a cancer. And then we come back to what Shailesh showed in his talk. You have a pathological complete response maybe in these patients, and they might have an excellent prognosis if you take it out.
Yeah. So the last question is from the YouTube. So what are the most relevant parameters for borderline resectable pancreatic cancer after neoadjuvant treatment?
Exactly as we spoke about. You need to have resectable vessels available on radiology. So if you can ideally get either stable disease or response in terms of tumor downsizing or shrinking, which may not happen in a large number of cases, but does happen. But as long as there is no disease progression, as long as patient general condition and performance status is well maintained, if there is a pre-treatment CA19-9, which is high, which has responded and come down, these are clearly good responders in terms of anatomy, biology, and patient condition. And if things are favorable, these are the factors on which I would operate. Exactly the opposite, disease progression, decreasing performance status, worsening tumor markers or tumor markers not coming down enough, worry of lymph node metastasis, etc. Perhaps you would think of continuing more treatment with chemo and or add radiotherapy rather than subject them in a hurry to surgery.
Yes, I couldn't add any more to that.
Okay, so my final question, if a patient is otherwise upfront resectable, but there is an infiltration of a replaced right hepatic artery, would you resect that artery and reconstruct it, or would you go for neoadjuvant in that setting?
So, very specific question, Matt. So when you say a replaced, so it's a dominant right. It's not something which you can sacrifice as a part of the tumor. Much of it would also depend on what kind of length of involvement are you talking of.
Let's say 2 centimeters in the middle. The root and towards the liver, both ends are free.
Both ends are free. It's right in the middle, and this is 2 centimeters.
Approximately, yes.
And nothing else is involved. Everything is R0, easy. Yeah, nobody has a clear data in terms of this, but yes, this is resectable. But this is by definition borderline resectable. And you have both the options in the last slide that I showed you. You can do safe, complete resection and subject to adjuvant chemo, or you are equally justified in giving neoadjuvant chemo, because if it is infiltrating one part of the artery, there is a possibility that there is no disease, etc. So it's resectable, but you can justify giving chemo and then doing surgery. I would also look at this patient's general condition. I would also look at this patient's CA19-9, and I would also look at other blood supply to the liver, because you are adding arterial anastomosis and having 3 other anastomosis, the bile duct, the pancreas, and the stomach. So do you want to add the risk of an arterial anastomosis is what you will have to decide based on the blood supply to the rest of the liver from the left artery, and sometimes to segment 2-3 from the left gastric or from the celiac, etc. You'll have to look at that and the intrahepatic collateral circulation, and then take a call, I would feel. Good question. Good question.
Thilo?
Yes, Matt, this is an individual situation, I think. Probably I would take it out if I had the feeling that the patient is the right patient to do this. And maybe I can add this comment on the chat question about what about the splenic artery? I think the splenic artery, everybody agrees you take it out. You don't care about tumor biology. So if you can take out this very short segment of the hepatic artery, as you mentioned in your example, this is not much different from you take out the splenic artery during a left resection because the tumor is invading it. But of course, by definition, this is not resectable upfront, as we talked all the time. So this is individual. But I think everybody would decide in the moment, in the patient, do it or don't do it.
Thank you. So thank you very much both for taking time on the weekend and helping us with all of our questions. This was an extraordinary day for me. Today is my birthday, and I think having
all the best.
Having 2 friends with me today was my birthday present. So I thank you personally, also on behalf of the Turkish HPV Society. It was our pleasure to host you here.
Thank you very much, Mr. President. Thank you, Matt. And thank you to the Turkish HPV Association. I hope we can meet in person sometime soon, but it was lovely to be here with you. And once again, have a lovely evening, Mert, and happy birthday to you.
Thank you so much.
Thilo, I hope we meet soon, but good to see you. And I enjoyed this webinar with you.
Yes, thank you very much to all of you from my side. It was my pleasure to accept this invitation. It was a fun to join all of you and to discuss all of these interesting topics. And I hope, as Shailesh said, that we can meet in the future again in person very soon. I hope this will happen. Thank you very much.
Thank you.
Thank you for participating, everyone. Have a nice day. Good evening.
Have a nice evening.
Bye-bye. Have a nice day.